Topcat trial. Definition: stands for treatment of persevered cardiac function. Heart failure with a aldosterone antagonist is a trial for heart failure patients with preserved systolic function.
All the echocardiographic parameters are improved after getting spironolactone. So a vision of HFpEF is someone with a history of hypertension or diabetes or old who has a thickened ventricle, stiff, non-compliant with fibrosis. And we know that the mineralocorticoid receptor effects are very effective in reducing fibrosis and mass. So we thought this was a reasonable approach and that we had a good chance of altering the pathophysiology. And this is important because nothing so far has worked, and not only hasn't it worked, the projections are that HFpEF will soon be the most frequent cause of heart failure because there are elderly population, obesity, and diabetes. So I'm going to ask Mark to tell you what we really did.
Well, fortunately, the National Heart, Lung, Blood Institute agreed that this is a huge unmet need and funded through a contract this research, and we did it with in collaboration with New England Medical Research Institute. And really, the concept was, let's take people who have signs and symptoms of heart failure and an ejection fraction greater than 45%. Then we
Applications in medicine. TopCat is a multi-center international random double-blind placebo-controlled trial of the aldosterone antagonist spironolactone in 3,515 adults with heart failure and left ventricular ejection fraction of at least of 45% recruited from over 200 clinical centers. The trial was sponsored by the National Heart, Lung, and Blood Institute of National Institutes of Health.
I was interested in the health science administrator position, and I specifically was interested in the program officer side because having been a scientist in the outside world and conducting research, I didn't want to get away from science too much. Basically, what it allows me to do is be involved in the bigger picture. I'm able to actually work with my colleagues to help shape the whole field. So at first, I was a little nervous when I came into this position because its title is health science administrator, and I was a little nervous how much administration would there be. And I've actually been really pleasantly surprised. A lot of what I do on a day-to-day basis is still very scientific in nature. To be successful as a program officer, you need to be flexible. Your day is never going to be the same from one day to the next. While we do have some administrative aspects of what we do, the fun things that we get to do are we get to plan workshops, we get to bring in scientists from all over the world, and so you've got to be willing to jump into an opportunity and just kind of go with it and see where it leads.
Pros. The primary endpoint of a complex of cardiovascular mortality, aborted cardiac arrest of hospitalization for the managed and heart failure. Secondary endpoints include all-cause mortality, new onset and diabetes mellitus, or atrial fibrillation, or and quality of life.
Hi, this is Clyde Yancey at the 2013 American Heart Association Scientific Sessions, and I'm delighted to bring to you science news from Scientific Sessions. This afternoon we have the privilege of discussing the results of the topcat study with the principal investigators. This highly anticipated and very much needed study really addresses one of the most important dilemmas we have in contemporary cardiovascular medicine. How do we treat the patient with heart failure with preserved ejection fraction? I'd like to welcome Mark Pfeffer and Bert Pitt. And first, I'd like to congratulate you men for an extraordinary effort in a very important trial. Let's get right to the heart of the matter, so to speak, and just tell us exactly how was the trial designed and what were your objectives when you did the study?
Well, the trial was a randomized placebo-controlled trial of spironolactone based on his pioneering work in reduced heart failure and post-MI. That was the rationale, plus all the mechanistic studies that Bert can tell you about. But with that, should we leave that on the table for the half of the patients who have heart failure yet preserved ejection fraction? And we said no. The NIH agreed, funded it by contract, and we did a 3,445 patient study, randomized to either spironolactone at a dose of 15 hoping to get to 30. You were able to go to 45, average 15 on median 15 against placebo.
So, Bert, what was the background? Why an aldosterone antagonist in this patient population?
Well, if you have a view of the pathology in your mind of heart failure and preserved ejection fraction, I think a lot of us believe there's diastolic dysfunction, fibrosis, and hypertrophy, and mineralocorticoid receptor antagonists, spironolactone and clarinone, have been shown to block fibrosis, reduce left ventricular hypertrophy, reduce myocardial inflammation, left atrial size. So we thought this would be ideal in this population where hypertension is the precursor overwhelmingly, though diabetes and age are also. And so our hypothesis was that spironolactone would reduce the diastolic dysfunction, fibrosis, and LV mass, as well as vascular stiffening, and that should lead to a good outcome.
So, Mark, Bert just used a very interesting phrase. This population, who are these patients? How did you identify them?
You know, we have to give credit to Charm for actually saying they exist. Well, epidemiologists said they exist, but no one wanted to try it because it's hard to prove they have it. But signs and symptoms of heart failure, if you find people like that, no matter what their ejection fraction, they're going to get rehospitalized and they have a higher risk of dying than just somebody with hypertension or diabetes. That's been shown. And that
Cons. Also, a significant portion of people with heart failure have preserved ejection fraction. None of the prevent heart failure therapies has been shown to be beneficial in this important and growing heart failure subpopulation. Now, a new NHLBI-funded study has failed to find a benefit in this group of spironolactone, which is a cornerstone of therapy for heart failure patients with reduced ejection fraction. But real investigations and heart failure experts believe it is too early to dismiss hope that spironolactone and other aldosterone antagonists may eventually be found to work on this population.
Although a significant portion of people with heart failure have preserved ejection fraction, none of the proven heart failure therapies has been shown to be beneficial in this important and growing heart failure subpopulation. Now a new NHLBI-funded study has failed to find a benefit in this group for spironolactone, which is a cornerstone of therapy for heart failure patients with reduced ejection fraction. But trial investigators and heart failure experts believe it is too early to dismiss hope that spironolactone and other aldosterone antagonists may eventually be found to work in this population.
Disease. The study population will include those who meet the inclusion criteria, some of which are male and female, aged 50 years of older, left ventricular ejection fraction 45% per local reading, heart failure which preserves systolic function, determined by signs and symptoms in conjunction with prior hospital admission, and our brain natriuretic peptide level. Control systolic blood pressure, serum potassium 5.0 ml liters.
Hello and welcome to the European Heart Journal. My name is Gerhard Hindricks and I'm sitting here in Davos, Switzerland for the 2013 Cardiology Update Symposium. And it's my privilege and pleasure to welcome Professor Bertram Pitt, who is one of the founding fathers of this symposium. Bertram, when did you start with Cardiology Update in Switzerland?
Well, we began planning this somewhere around 1973. I was at Johns Hopkins University at the time in the cardiology division, and I spoke to my chief, Dr. Richard Ross, about putting on a course in Switzerland, and he said fine. And he had a former fellow, Dr. Paul Licklin, who was from Zurich but had returned to Europe, and I think We had the first course in 1975. I think by that time, Paul Licklin had already gone to Hanover as chief of cardiology. The first course we thought was a great success. There were only 75 participants here, but everyone enjoyed it. And at the end of that course, we said, well, maybe we should do it again. But we didn't want to do it every year because we didn't think there would be enough new changes. So we said, let's do it every other year. And gradually over the years, it's grown. I think 2 years ago, we had about 850 people here. And I think that just shows the quality. I think in the past, to be honest, several drug companies would pay for people to be here. But in these days, drug companies are not doing that. And the people who are here, and this year it's over 550, are paying their own way. And that shows they're getting something from it.
Exactly. It shows that it's attractive, it's unique. What creates this special atmosphere here in Davos?
Well, I think if you go to the national meetings, American Heart, American College, ESC, there's a tremendous amount of information. But I always feel I'm in the wrong place at the wrong time. There are so many things going on, it's hard to focus. Here, there are main sessions, there are some satellite sessions, but you can sit here for the week and really get a good refresher course in cardiology. The other thing, I think we've changed a few careers along the way. We've changed clinical practice. And for me, as a clinical investigator, coming to these meetings, I meet outstanding faculty, and we create new ideas and new research. Just at this meeting, I formed 2 more new collaborations. Maybe they'll never happen, but we have ideas. We're trying to see whether we could make it work. And I think that's the fun, in a small atmosphere where people meet each other at dinners and receptions, and during the course, there's tremendous interaction, and the participants as well.
Yeah.
Thank you.